Okay, Chapter 25. Chapter 25 covers behavioral and psychiatric emergencies and suicidal ideations. This chapter, unfortunately, is something that we deal with more than I think most of us would like to. Behavioral emergencies tend to becoming more and more prevalent in our society. We have a lot of emergency room and emergency department beds that are being occupied every day by psychiatric patients who really, in all honesty, don't in most cases have a medical condition making them there, making them that way. It's really truly a psychological condition that no amount of emergency room care is going to deal with. So unfortunately we see a lot of these, and I think we're only going to continue to see more of them. Now, sometimes we also have to keep in mind, and before we go much further in the chapter, we need to keep in mind that behavioral emergencies, in many cases, are potentially from an underlying medical condition. So we have to constantly be wondering, is this really a medical condition gone awry that we need to look further for a cause? So remember, sometimes we get people walking around acting like they're stoned or acting out with extremely bizarre behavior, only to find out that the person accidentally overdosed on a medication. The person is hypoglycemic, and we need to restore their sugar to a normal level, or they're having a stroke and their behavior is significantly different. So that's why sometimes we see these people in the emergency settings, is because it's really more of a rule out, because there's the potential for it to be a significant medical problem. Then unfortunately they get into the system and they get stuck there until they can find a psychiatric bed. So our objectives are located on 587 and 588 in the text. There's a multimedia video on safely restraining a patient. I highly recommend that you watch this. It's not something we have to do a lot, but when it comes down to it, it's usually a high stakes time. So spending a little extra time playing around with them is going to benefit us. So nature and causes of behavioral and psychiatric emergencies, emergency care for behavioral and psychiatric emergencies, emergency care for the potential or attempted suicide. A lot of times patients have a behavioral or psychiatric condition but are really not of much potential for harm to themselves or to us, which would be a homicide. But emergency care for aggressive or hostile patients, and these people start to get a little bit more unruly. How to restrain a patient safely and effectively, and then any medical legal considerations in behavioral and psychiatric emergencies. So patients may present with unexpected or dangerous behavior. So basically it is a behavioral emergency when a patient is acting in a manner which is unacceptable to society. So to the patient, family, community, and so on and so forth, and potentially presents a potential for harm to himself or others. So these can result from various things: stress, physical trauma or illness, drug or alcohol abuse, and then probably in most cases a psychiatric condition. I think we all have recognized the person who occasionally has one too many to drink and starts to become pretty bizarre. I think we've all seen and dealt with and perhaps have spent too much time with somebody in that condition. But the other things, the stresses and the traumas, psychiatric conditions certainly play a big part, and I think a large majority of them are psychiatric based. So behavioral is the manner in which a person acts or performs, and like I said, that behavioral emergency is that abnormal behavior which is deemed unacceptable to society. The patients can be confused, they can have altered mental status, hallucinations, they may be just simply withdrawn, they may be completely trying to block out all of reality and everything going on around them, or they may be manic where they're just all over the place. So some psychiatric conditions or mental disorders, the more common ones we talk about, the bigger families of these, are anxiety or panic disorders, depression. So anxiety is revved up, depression is slowed down. So anxiety is your patient that looks like they're on uppers, and depression and the patient that looks like they're on downers. And it's very possible that they actually are. Bipolar disorder, they swing both ways. They go from being very depressed to very manic, very depressed to very manic. And then schizophrenia. Schizophrenia is when you start to throw some alternative realities into this whole picture. So you go from having some anxiety and some depression to, in many cases now we have people who are hallucinating and paranoid. So the non-psychiatric causes, and these are the ones that we need to try to rule out in the field first before just defaulting to behavioral emergency. It's so easy for us to come up on this unconscious person that's laying on a park bench, slurring their speech and acting bizarre, and say, oh, they're just drunk. It's easy for us to say that because it's like we've seen it, we believe it, we've dealt with it too many times, and we just get tired of it. But in reality, many cases in which the patient's acting this way, there's really something simple we can fix. So some things to look at there, determine to make sure it's not a life threat. Hypothermia, hypoxia, strokes, head traumas, substance abuse, hypothermia, hyperthermia, hyperglycemia for that matter, are just a handful of potentials that could give us this very odd behavior. I believe I mentioned in the diabetic chapter about going on a call once with a very, very large farmer who was just as nice as can be, but was a diabetic, and he had a very, very small wife, and getting called to their residence one day, and it looks like he's just trying to beat the tar out of her, but in reality, his sugar had become so low from being so stressed for the harvest, and he had not been feeling good lately, that his sugar was just all out of whack. And so it could have easily been dismissed as, wow, this guy snapped, something is wrong with him, we need to get him restrained and take him to the nut hut. But having known what we knew about him and being able to get some information, we knew, oh, he's diabetic. We can check his sugar, and oh, lo and behold, he's hypoglycemic. And there's something we need to do and can do about that. So situational stress reactions. We have stress in our life. We go way back to, like, I think it was the very first week of class. We talked about well-being of the EMT and talked about the stressors that we have in our job. Well, people have stress in every job, in every lifestyle. There's stress. We have eustress, EU stress, which is good stress. So things like, in most cases, things like getting married, having a baby, getting a promotion at work, those sorts of things are eustress. I mean, they're good. In the long run, they're good. But sometimes they really present us with some uncertainty. So when we have that, we have to work our way through that a bit. And then, of course, the ones that we always like to think about is the distress. And distress is bad stress. So divorce, job loss, loss of a loved one, that is distress in most cases. They both tug on our stress level, and they can both have some very short-term effects and be very hard on us. But it's more often the long-term effects that we have to look at, is how are we going to come out in the long run. So some of those stressful situations, we talk about fear, grief, anger. Those are all big things that come up. If we're scared of the unknown, we're missing somebody, or we're mad about something, we've gotten fired. All those things, they can greatly upset our balance of everything being homeostatic. So when we care for patients with situational stress reactions, do not rush. Okay, if we're dealing with a behavioral emergency, a psychiatric condition, we honestly have got to be ready to be on scene for a very long time. These people do not always cooperate, and sometimes it's going to require multiple amounts of resources, lots of phone calls, lots of talking to even get to a stage in which we can even consider transporting. So try to inform them that you're there to help. Remain calm. Even though they may be flipping out, calling you every name in the book, throwing stuff at you, you need to remain calm because they feed off of your emotion as well. So you keep your emotions under control. Listen to the patient. Use some active listening techniques. Say, if I'm hearing you right, you're saying this. But then don't play into their delusions. So if they say, well, ask that purple dinosaur over there, you may have to tell them, I don't see the purple dinosaur, but if you're telling me that it's there, then I'll listen to what you have to say. Be honest with the patient. Now, when we say be honest, don't lie to them in something that they're going to catch you in, but you don't always have to spill 100% of the beans. So you don't always have to tell them, hey, if you don't cooperate, we're going to get the cops here. We're going to get you in handcuffs, throw you in the back of a cop car. That can actually make more harm than good. And then stay alert for changes in behavior. I mean, you may get there and they may be very manic and very up over the top, and then next thing you know, they swing towards the depressed side. So emergency care for behavioral psychiatric emergencies. The range of presentations that we deal with, everything is going to be so different. We may have people that are harming themselves, people that are attempting to harm others. Maybe they're just simply withdrawn. They perhaps have a lot of agitation. Maybe their behavior is just completely out of sorts. So one call that I remember going on very vividly, getting called for a woman on the side of the road that was naked and waving at people. Well, that's generally not something that we would consider normal here in the United States. They can be threatening towards you. And in many cases, they probably are bluffing, but we are not going to call them on that bluff and see what happens. And with that potential risk to want to harm themselves. Sometimes this is just a very, very long, drawn-out assessment process. As we talk to them, we're getting itty-bitty bits and pieces of information in extremely long periods of time. So to interact with these patients, we need to obviously identify who we are, what our role is there, what we're going to do there, speak slowly and clearly, and direct eye contact. Direct eye contact lets them know that you're serious and you're confident, and it helps to establish that rapport. Listen to them, don't judge them, don't be saying anything disparaging. Use an open, positive body language. Remember, crossed arms in front of you, and I'm terrible about this because that's a natural position for me to assume, but crossed arms in front of you generally conveys, I don't really care what you have to say, when to me it actually means I have nothing else better to do with my arms and they're just hanging there, so I'm going to cross them. But other people interpret that differently. Also, having your hands in your pockets is probably not a good idea either. If they make a quick move, you're going to have to quickly get your hands out of your pocket, and it can be a matter of several seconds. Don't enter that patient's space. Try to stay outside of that 3-foot radius. Stay out of arm's reach from them, and then watch very closely for any behavioral changes. You need to very carefully perform your scene size up, and you need to rely on everybody else that's responding to this call to do the same. We may need to chat and have some people, as we're conversing with the patient, have other people looking around, looking throughout the house or the scene in general. Try to gather clues, because a lot of times the whole story isn't what we get from the patient. In most cases, the story doesn't even really match what the patient has to tell us. So perform your primary assessment. Now, primary assessment in many cases for these people is across the room. It's from the doorway. So we're doing things like assessing their mental status, assessing their respiratory drive, and in most cases we're having to do some sort of an assumption on their cardiovascular status. We can look at their skin. Is it wet? Is it dry? Is it red? Is it pale? Is it blue? But we may not be able to get a great pulse off the bat. You know, a lot of times we can count respirations from across the room, but we can't count a pulse. Try to gather a thorough history. Try to ask them for, well, do you have any medical conditions? And remember, you're going to have to perhaps explain these things a little better. Can you tell me what kind of medications you take? Do you take any drugs? And sometimes drugs is not the best term to use. Maybe do you do any substances outside of your normal physician medications? Do you do any recreational substances? So our common presentations, panic or anxiety, and this is, I think a lot of us have seen panic and anxiety in people. They're very, very excited. They're very, very upset about something going on, and they're acting out, and they're talking 100 miles an hour, and they maybe can't sit down, and they're clenching their fists, and they're running around, they're pounding on the walls. And do they have an unusual appearance? Do they look disordered? Do they have poor hygiene? That in and of itself is not enough to say it's a behavioral emergency, but it helps to support that, because most people take some pride in how they look, and poor hygiene is usually something that people stay on top of, although not always. Very agitated or unusual activities. So are they trying to make the TV change by talking to it? Or are they trying to have a conversation with somebody that's on the TV? Are they trying to use pieces of paraphernalia or equipment around the house for things that they're really not intended to? Unusual speech patterns. Do you hear them talking in what appears to be a normal voice? And that's something you can ask bystanders. Is this their normal voice? Or is there a very odd pattern to their speech, a very different, strange tone to their speech? Are they being self-destructive? Do they have a knife? Do they have a gun? Do they have a handful of pills? You know, there are a bunch of empty pill bottles laying around. And are they being violent or aggressive? So are they charging at you or other people that are on scene? Have they attempted to attack somebody, or have they actually attacked somebody that's there on the scene? So for patient care, you got to treat the life-threatening problems, and sometimes this is easier said than done. My story about the big, tall farmer diabetic guy, remember, it took several of us to get him wrestled down to the ground and down on his face, basically, so he had a little less control over the situation. He was a little easier for us to handle, so I could give him a shot that would help to raise his blood sugar. And then once I was able to get his blood sugar starting to rise, then I could do a little bit better job of treating his blood sugar. So it just all depends. You may have a very difficult task on your hand trying to treat this life-threatening problem. You know, you may not be able to get oxygen on them. They're just reaching up and tearing it away. So there's lots of potential issues here that we have to consider. We may need more help. Consider a medical or a trauma case. Is it possible that this person had a car wreck 2 days ago and now has a small bleed in their brain, and that's leading to their odd behaviors? Follow the general rules for positive interaction. So we're not playing into their specific hallucinations. We're trying to converse with them in a positive manner, trying to stay calm. And then consider involving family or friends. Often the family or the friends are one of two things. They're either A, the problem, or B, they are going to assist you in getting the patient to cooperate. So suicide. Suicide is the 8th leading cause of death in the United States, 3rd leading cause of death in the 15 to 24-year age group, and those rising numbers in the geriatric population. We're living longer in general, and sometimes patients aren't aren't suited to live longer. Maybe they've lost a loved one, or maybe they have been diagnosed with a terminal disease and they don't want to deal with that. I've seen this a lot where a person over the age of 60 or 65, even some into their 80s, where they have just said, that's enough. I don't want to be a burden on anybody, and I'm not willing to go through this treatment, or I missed my wife, and that's it. So some risk factors that go along with this: they have a pre-existing diagnosis of depression. Not always do they have that, though. They don't always have a diagnosed psychiatric condition. Sometimes they've been very good at covering that up. Age, again, the teenage or the early adulthood and the elderly population. They may have a suicide plan. Usually this is not something people do on a whim. They usually have taken some time, considered the options, and maybe have developed a plan. They may or may not have written that down. They may or may not have written a letter saying, hey, I'm sorry, this is why I'm doing this, I love you all, and goodbye. Stress level. Stress level suddenly has jumped way up there, and they can't deal with it. They may also have some sudden improvement. That sudden improvement may be as a sign that, hey, I've finished putting my plan together and it's just a matter of making the timing right, so all of a sudden I feel good, I feel happy because I know the end is close. Recent emotional trauma, substance abuse. Substance abuse is probably more common than we think it is when it comes to suicide, because it takes the edge off and it makes people maybe a little bit more willing to give it a shot. So our suicide patient assessment: explore the following possibilities. These are all the things that I just talked about, really. Depression, stress levels, recent emotional traumas, age, drug and alcohol abuse, threats of suicide, a suicide plan, previous attempts or threats at suicide, and sudden improvement from depression. So all those things, like I mentioned previously, have the potential to be a red flag for suicide. Personal interaction is important when it comes to dealing with a potential suicide patient or a suicidal ideation, somebody who's talking about doing it or made some sort of an attempt. The scene safety has to remain paramount, because if they're willing to do something to harm themselves, they may be willing to do something to harm you so they can continue to harm themselves. So, scene safety: identify and treat any life threats. Perform your detailed history and physical exam if it's safe to do so. Detailed, of course, is good if we're looking for specific things. Reassess frequently and then notify the receiving facility. In many cases, law enforcement will need to be notified about this as well, because in many places it is still illegal to attempt to take your own life. So think about it. Patient's 23-year-old male. His girlfriend called 911 after a domestic. He's uncooperative and refusing treatment. The girlfriend reports that he's been depressed and suicidal. He owns a gun and has threatened to shoot himself. Can you treat the patient if he did not call? Yes, you can, although you need to be cautious in the way that you approach that, because you may need to involve law enforcement, mental health systems, physicians and whatnot, medical control, to everybody kind of collaborate and trying to get the consensus to transport this person. Should you believe the girlfriend? Well, I think you kind of have to believe the girlfriend at this case, because in most cases, if we don't believe her, something happens, the patient does end up killing themselves, we can be held liable. And does the patient need treatment or transport? Again, it's going to depend really on what we get out of the patient. We have to rely on some of the history we get from the girlfriend, and then also what we get out of the patient, look at the scene clues. So, can you treat and transport the patient against his will? Again, we have to go back to that. Is he a potential harm to himself? When we go back to the overall concept of giving consent, we have to remember, is this person able to give us an expressed and informed consent, or is this a person who is not within their right mental faculties to give us that? So what should you do? Again, talk to everybody. Talk to medical control, talk to law enforcement, talk to family members. If we can get him to cooperate and go with us, that makes this whole job a lot easier. So consider some clues for hostile patients. Any dispatch information that we may get, information from family or bystanders, the patient's stance in the room. Did we see anything laying around? Do we see weapons? Do we see pill bottles? Do we see drugs? Ensure that there is an escape route for you. You need to have an out. You don't want to get your patient between you and your escape, because again, scene safety, personal scene safety, is our number one. Do not threaten the patient. If you try threatening the patient, of course, the patient's going to potentially lash out at you. They're going to threaten you back and potentially take you on. And then, of course, stay alert for weapons of any type. Law enforcement has got to be on scene with any of these patients. If we're dealing with a behavioral emergency patient and we're on scene with them, we've got to have extra sets of hands around. We need to have law enforcement to back us up, not only in a legal sense, but in a physical sense, an emotional sense, to give us that extra set of hands when we're having to deal with this. So when we're assessing these patients, ensure the safety of yourself. Attempt to calm the patient, attempt to get your thorough assessment, and then if necessary, then you have to result in restraining the patient. But really, those are in a pretty good order. Ensure safety for yourself, your crew, and any bystanders. Then we really need to try to calm them, because if they're not calm, we're not going to get an assessment. After we get an assessment and we're still very strongly suspicious that this is an issue, then if they're not able to cooperate, we have to consider restraint. So size up your scene, request additional help. You should always be requesting additional help, at the very minimum law enforcement, and in some cases maybe ALS. ALS does have a number of drugs that they can give, maybe in a quick injection form. They're starting to have some new abilities to give certain types of sedative drugs really in a quick burst up a patient's nose, where you just take a little syringe and real quickly shoot it up their nose, and so that's a possibility. Seek advice from medical control, of course. If you're going to have anything that outside the ordinary, go ahead and give them a holler. Watch for sudden changes in behavior. Did they swing from one end of the spectrum to the other? Frequent reassessment, and then consider restraint. So what's reasonable force and restraint? Reasonable force is force necessary to keep the patient from injuring themselves or others. Primarily, it is geared towards protecting you and others, but in some cases we may have to use a force to keep them from trying to harm themselves as well. Reasonable is determined by many different factors, of these, some of which are patient size and strength. So in most cases, is it going to take 4 people to restrain a 3-year-old? Now, granted, we probably don't have a lot of 3-year-olds with a suicidal ideation, but if we have do we have a former offensive or defensive lineman off the football team trying to harm themselves versus a 12-year-old petite little girl? We obviously have significant differences in what we're probably going to need. What is their type of behavior they're displaying? Is it aggressive and and physical and violent? Or is this something that all of a sudden we've decided, okay, enough's enough, we're going to transport. Now they're kind of trying to struggle a little. Difference. Mental status. Are they for the most part towards the normal end of the spectrum here and can somewhat be cooperative, or are they completely uncooperative and lashing out? And then available methods of restraint. At the EMT level, you really have physical restraint is one of your only options. We can use certain types of restraint devices, a lot of which today have Velcro straps to get somebody restrained and try to take away some of their ability to swing at you. Again, like I said, ALS, though, they very possibly could use some medications, and chemical restraint is a good thing. So some systems do not allow restraint without police or medical control orders. You need to know what your system does allow. In most cases around here, when I had to deal with a quick restraint situation, it ended up being law enforcement was on scene, and we basically told them we need to do something about this, and we need them restrained. And in many cases, the law enforcement officers handcuffed them. We've taken 2 sets of handcuffs and handcuffed one arm to each cot rail. The potential issue with this, though, is if you transport this patient that's handcuffed to your cot, one to each side, and you don't have somebody there that can get them out of those handcuffs, and the law enforcement officer didn't go along with, you could get in a world of hurt real quick. So this patient is basically having to lie flat on their back because they can't twist and turn, and now they start to vomit. And if they start to vomit, yeah, you can attempt to turn their head to the side, but it may be so much that they really need to be turning their whole body to the side. So never attempt to restrain without the proper authority and sufficient assistance. Somebody will get hurt or sued. So when restraining a patient, you must have adequate help on scene. You guys need to develop a plan of action. And when you're developing your plan of action, there needs to be a discussion about who is going to be doing what, who gets the head, who gets the right arm, who gets the left arm, what are we going to do? Are we going to go down to their face? Are we going to go onto their back? Somebody going to apply this certain restraint device? The police officer going to handcuff them? Whatever. So talk it out away from the patient before you have to go there. Stay beyond the patient's reach until everybody's in position and prepared. So you may all have to start kind of working your way in from the periphery. Once it's time, and everybody needs to know on the signal, you go to it and you do what you need to do. One EMT talks and calms the patient. Multiple people talking just is going to make this situation much worse. It requires a minimum of 4 people, 1 at each limb, and in many cases we also would like to have somebody at the head to keep them from banging their head around. Restrain all the limbs with approved leather restraints in a supine position always. I don't like that term always there, but more times than not they need to be supine. Putting them face down is dangerous. So if we needed to put them on their side, and then leather is the best if we have them, but leather is not nearly as adjustable as a lot of the newer versions, but they are stronger. So leather restraints are made out of leather and metal. And the newer restraints are usually some synthetic materials such as kind of a lycra-like material and Velcro, as well as some kind of cloth straps and whatnot. The EMT is always responsible for the patient's airway. That's something we have to keep constantly looking at. Is their airway okay? Is their airway okay? Is it something we need to do? Ensure that the patient is secured adequately throughout transport. Psych patients also tend to try to get very creative and will try to all of a sudden swing to your side and say, oh, okay, I'm going to cooperate, everything's fine, just untie me and I'll be cool. And in most cases you would do this and you're going to find yourself in a world of hurt very quickly. I would recommend taking a law enforcement officer with you as well. you can apply a surgical mask to spitting patients. Patients, once we've secured them, in many cases are going to now spit on everything possible. So a surgical mask or even a non-rebreather with some oxygen can be helpful because it prevents them from spitting on everyone. Reassess and frequently and document thoroughly. Excited delirium. This is a concept that's really not new, but it's just fairly new that we start talking about it. Excited delirium is an extremely agitated or psychotic behavior during a struggle, which is followed by a cessation of struggling and then into respiratory arrest and potentially death. The patient is often hyperthermic and shouting incoherently, so they have a high fever. They're shouting incoherently, usually preceded by stimulant use, can be cocaine, and it's often linked to improper restraint and a position in which the patient cannot adequately expand their chest to breathe adequately. So it's called positional asphyxia. So kind of like we straitjacketed them. Be alert for this sequence of events. So if you've got this patient shouting, they're hot, they potentially are on drugs, we have them potentially restrained, we have that risk for excited delirium. So think about that when we're getting ready to immobilize people. Transport to an appropriate facility. Not all hospitals are prepared to treat behavioral emergencies. They don't always have the appropriate facilities and rooms to do that. Now, most emergency rooms these days have a safe room or two in them that have been designed to hold patients of behavioral emergencies. You're going to need to know what your local protocol says about who to take where. A couple of medical legal considerations. Consent. Refusals and restraints cause significant medical legal risk. So when we're talking patients who don't want to go and they've done a good job of making us believe them, we run that risk of we leave and then they do something wrong. And one of the things that's, I guess, kind of a bummer in the way the current systems work is there are a lot of places that patients come into the emergency room with some sort of a complaint and some sort of a psychiatric emergency, and they're basically required to keep them even after doing an assessment, because if that patient gets dismissed, goes home and kills themselves in the next 72 hours, then the physician that saw them is liable. So, laws will typically allow providers to treat and transport patients against their will if they are a danger to themselves or others. Now, this is the case, but like I said, the more people we involve in that decision-making process, the better. Local protocol may require the presence of medical control and or police. I say get them both. You may not need medical control physically on scene, but you should be chatting. Sexual misconduct. Behavioral patients, especially those requiring physical contact such as restraint, sometimes will accuse EMS providers of sexual misconduct. They do this with law enforcement as well. They're trying to do anything to save face so they can get out of whatever they're into. Please attempt to have a same-sex provider attend to or at least be present at all times with that patient. So gals with gals, guys with guys. And then have a third-party witness present at all times. So if it's appropriate to have a certain family member right along, that may be good, provided that they're within their right mind. Law enforcement, also a good resource to have on hand. Here it talks about the video talking about safely restraining patients. So again, to review, ensure your own safety and those of your crew and then any bystanders and of course then your patient when caring for your violent or potentially violent patient. Patients with behavioral problems are in a crisis. They need compassionate care, and in often cases it's going to be over a longer period of time. That can be our standard 20-minute ambulance call. It could be a 3-hour ambulance call. Always consider abnormal behavior to be altered mental status with a medical or traumatic case or cause. You have to rule those out or have to have a strong suspicion that they are not the case. History helps. If you are We're talking to family members that can tell you, oh, this happens every several months. They get feeling good, they quit taking their meds, and this is how they respond. Because treatment of these patients usually requires long-term management, little medical intervention can be actually done in an acute situation, but how you interact with them is crucial for their continued well-being. If they have a bad experience with us, any other time that they call the ambulance from now on, they're going to instantly believe, or actually that they may not call, but somebody calls, they're going to instantly have that flashback to, oh, I remember last time I dealt with these guys. Safety is the priority. Psychiatric and behavioral emergencies are very, very prevalent in our society, and you need to treat them as you would any other potentially life-threatening disorder. Try to rule out any physical causes. Psychiatric and behavioral emergencies can present differently depending on the disorders. So there are best practices for us to employ, such as approaching, assessing, and treating these patients. And you have to look at what local protocols suggest and dictate when you're determining whether restraint is necessary. So some things for you to consider. What methods help calm a patient suffering from behavioral or psychiatric emergency? What can you do when you scene size up reveals it is too dangerous for you to approach your patient? And what factors help us assess the patient's risk for suicide? So our critical thinking question is, you respond to an intoxicated minor who is physically aggressive, threatens suicide, whose parents permit you to treat but not transport the patient. How would you manage this patient? First of all, I don't know that the parents are even completely aware of the severity of the situation, so attempting to get the parents to agree to allow you to treat and transport this patient would be our first step. If they're intoxicated and physically aggressive but threatening suicide, we need to have somebody stay present with them but in a safe distance until we're able to make some further decisions on whether transport is going to be necessary or allowed. Of course, involving law enforcement will be huge here, and that could be difficult, particularly if the parents don't want law enforcement to be aware. But getting law enforcement involved can also help us out on this situation, as well as getting medical control involved. So having medical control possibly even talk to the parents, say, here's our concerns, here's what the EMTs have told you, here's what our concerns at medical control are. We need this patient to be transported.